So, good evening. From Nizat, welcome to all the respected delegates of today's webinar. Myself, Amar Sahu, at Vijayawada in Pharmacare Division of Sun Pharma, makers of Nizat, as well as Sepodem Montec Apex. Thank you for joining today. At the outset, let me wish a very good evening to our speaker and esteemed panel members. And Sun Pharma, being a number one company, always wants to associate with contribute to various scientific programs. We keep on doing several live surgical workshops and webinars to facilitate the knowledge sharing programs, and we are committed to do so in future. At Sun Pharma, we feel extremely proud to associate with such an eminent group of speakers and audience from across the country. We feel extremely happy to continue a series of webinars, which we are conducting every month on behalf of AOI AP branch. And in today's webinar, the main objective of this series is to concentrate on basics, which will be useful especially for young ENT surgeons as well as ENT PGs. In each series, we will have eminent speakers and panel members. So today's topic, when medicine meets law, that medico-legal issues in ENT, neurotology and sleep practice. And today's speaker, Dr. Krishnan Rajwar, MS ENT, Safdarjung Hospital, with MBA Hospital Administration, gold medalist. Welcome, sir, for today's webinar. And today's topic moderator, Dr. C. Sai Balram Krishna, Consultant ENT, Executive Director and HOD, KIMS Icon Hospital. Welcome, sir, for today's webinar. So, at the same time, I welcome all the esteemed committee member of AOIAP State, and our speaker will be happy to answer all the questions asked by you in question and answer session at the end. Please feel to ask your questions. Now, without taking much time, I'll hand over the session to Dr. Sai Balram Krishna, sir. So we'll formally introduce our speaker and proceeding the program. Sir, over to you, sir.
Yeah, thank you, sir. Good evening, everyone. It's a pleasure always to be a part of the academic sessions. First of all, I would like to thank the AOI AP branch and Sun Pharma for making this program a reality. I'm Dr. Sai Balram Krishna, an ENT surgeon for the last 25 years. It's an interesting topic. Today, I'm the moderator for the topic, which is very interesting. When I seen the heading, I was very much interested and amused. And so important that, for the juniors as well as for the seniors to listen to it, for the seniors, what they are missing, the fine points, and as well as for the juniors from the beginning, if they inculcate the art of communicating and documentation, it helps a lot in a long way in avoiding so many situations which are not very welcome in the practice. So the topic today is that medico-legal issues in ENT, where medicine meets law in ENT edition. We have a very great speaker whom I would like to introduce to you all. To make it very short, he is a very illustrative career. He is Krishnan Rajbar. He has, apart from MBBS and MS ENT, he is also a hospital administrator who has done an MBA. And he also has fellowships of middle-ear surgery in allergy and immunology from USA, vertigo management, sleep medicine, endoscopic sinus surgery, Royal College of Surgeons, UK, pediatric allergy and asthma, communication and student wellness. And he has additional qualifications like certificate course in telemedicine, completed 1.5 telemedicine consultations, board certified medico-legal consultant. Is a PhD, MHPE, LLB, fellowship in healthcare computational imaging, fellowship in AI, data privacy, and cyber law. He is affiliated to Apollo Hospital, Delhi, ENT Allergy, Vertigo, and Sleep Clinic, Delhi, National President, AIMA, Senior Advisor, Healthcare Risk Management from firm, Senior Medico-Legal Consultant, Honorable Supreme Court and Delhi High Court. And he has many achievements like Akhil Bharatiya Chikitsa Samman, Bharat Gaurav Shri Samman, IMA Award for Outstanding Performance 2021, ex-National Academic Head, FAIMA, ex-co-convener IMA, invited in more than 170 national and international TV programs. He's a convener committee on guidelines for AI in healthcare, an International Biology Olympiad gold medalist, AR1 in pre-medical entrance exam, Best Poster Presentation Award, author of 40 plus medical books, including 3 upcoming books on AI in healthcare. So many publications of assessment of gustatory function in patients of chronic rhinosinusitis, allergic bronchopulmonary aspergillosis in children with asthma, comparative analysis of PCR versus conventional techniques in bacterial detection, multiple publication in rhinology, allergy, and head and neck surgery. I welcome you, the speaker, Dr. Krishan Rajbar. Please take over.
Thank you, sir, for nice introduction. Good evening, one and all. So today we'll discuss all the. This is one of the very prominent topic and a confusing topic from for many ENT surgeons. So today we'll discuss all the medical legal issues in ENT as well ENT practice as well as the various subspecialties like allergy, neurology, and sleep practice, along with the emerging branch cosmetology and cosmetic surgery and all. Along with that, we'll discuss certain, this is something about me, we'll discuss certain emerging medical legal issues, which is troubling many young doctors. So these are my work in the field of medical legal sciences. I am ENT surgeon as well as practicing medical legal consultant. I have my own medical legal firm. So at the outset, we need to know how healthcare models have changed over the time. Am I audible to all?
You are audible.
Yeah,
you are very clearly clear.
Very clear, loud and clear.
So how healthcare models have changed over the time. So earlier, prior to 1990s, we had old paternalistic model in which doctor was only decision maker and the patient has passive role. But over the time, with the advent of increased awareness for patient rights, the practice has changed to modern autonomy based, in which doctor and patient both have shared decision making, and the patient now has taken the active role, and the patient now is more aware of their rights and all. So we'll see pre-1990s, as I have discussed, there are paternalism. Then there was transient rise of patient rights and awareness about that. Post 2010, we have patient autonomy and shared decision making. So these are subspecialties, and almost all subspecialties have their unique niche of practice and consequently unique medical legal issues. So what we should do while understanding? So we'll target these things under following domain, and consequently we'll develop our understanding of medical legal issues and medical legal principles, and consequently we'll improve our safeguardness or guardrails in medical legal issues. So first is mitigating risk. So we'll understand and reduce the potential legal exposures. Consequently, we'll refine protocols. In refining protocols, we'll master communications and we'll understand what are the best practices related to consent. Then we'll discuss certain cases, certain landmark medical legal cases related to our ENT practice. And we'll apply, we'll understand what went wrong in those cases, and we'll apply insights from those cases. And consequently, understanding these all things will elevate our practice. So we all know that due to the very nature of ENT practice, we are prone to more medical legal risk. So what are those reasons? There is small operative field. Consequently, the limited visibility and intricate anatomy increases the risk of unintended injury. Similarly, high risk emergencies, we are dealing with the airway and all, and consequently sometimes patients come to us in a very dire emergency, very serious condition, as well as sometimes we are not able to save the patient, so that can also land us in medical legal trouble. So we'll understand in the coming sections of the session how documentation can save us. Then there are complex consent issues. Then with the rise in cosmetic surgeries, the patient expectation has risen, and we as a ENT deal with many cosmetic surgery, ranging from rhinoplasty to many others. So this is the most important slide of this whole presentation. If we as a doctor, we as a ENT surgeons master this slide, will increase our legal defense in the code of law. So we have to take care of these 5 things. So duty of care. So as a ENT surgeon, we have legal obligation to exercise reasonable skill and care in the treatment of patients, and this ranges from proper diagnosis, treatment planning, and executions. Next come the informed consent. So ensuring patient understand the procedures, risks, benefits, and alternatives before agreeing to the treatment. And this is, as it is mentioned, this is a dynamic process. Means we have to update our patients and their immediate relatives about the progress of the treatment, whether the patient is improving or deteriorating. We have to inform that patient and relatives on a daily basis. Standard of care, the level of care that a reasonably prudent healthcare professionals would have provided under similar conditions. So the level of care which is expected changes with the time. So what was the standard of care or level of care expected from a ENT surgeons 10 years back is not now. So we have to provide care, provide surgeries, provide treatment as per the standard expected in the year 2026 or in the current time. So we have to take care of this. Good documentation. I always speak in conferences, in medical legal conferences as well, that documentation is the greatest defense. So I always tell to my medical legal clients also that you have to document as if you have to defend those things 5 years down the line. Why 5 years down the line? That you will not be able to recall the cases from your memory, what happened in that case. So you have to document effectively so that you can prove in the code of law that you have given the treatment as per the standard of care prevalent at that time, and you have taken due diligence. So this is important. So comprehensive, accurate, and timely record keeping is the first line of defense in any medical legal challenge. If it's not documented, and it didn't happen. 3 months back, I was speaking in a dental conference. So one maxillofacial surgeon asked me, if I haven't documented, so does it mean that I have done medical negligence, or there is a case of medical legal negligence? So then I answered it like this: see, if there is no documentation, it doesn't imply that there was medical negligence. But in a code of law, without documentation, it becomes very difficult that there was no medical negligence, or the care which was provided was as per the standard protocol or standard of care expected at that time. So it's not that we can't defend, we medical legal consultant or medical legal lawyers can't defend you in a code of law, but it becomes difficult. Then comes the effective communication. In my medical legal practice, I have seen that effective communications solves most of the problem of medical legal litigation. So we have to be clear, empathetic. Ongoing dialogue with patients and their family builds trust and manages expectation. It doesn't only protect us from medical litigations, it also somehow improves our rapport in the eyes of the patient, and consequently, patient wise, we also get more patients, and consequently our practice build up. And this significantly reduces the likelihood of complaints. So these are 3-4 sites in which I have tried to simplify how court understand the complications or anything related to the medical negligence or medical legal litigation. So in the case of otologic surgeries, if there is facial injury, the complication will be facial paralysis, and the legal risk will be negligence allegation. Similarly, if there is post-operative hearing loss, complication will be hearing deterioration, and the legal risk which will put you in medical legal litigations is failure to counsel. So we have to take it. We have to understand these all surgery in these aspects. Similarly, coming to the face and nasal surgery, if there is CSF leak, complications can be life-threatening infections, including meningitis and all, and surgical error if unmanaged. So one thing I would like to highlight here, that complications, it's not that court doesn't expect us किसी surgeries में, in any surgeries there will be no complication, but if there is complications, whether we are able to identify it within time, and whether we are after identifying, after recognizing, we are treating that complications with due diligence and as per the standard of protocol prevalent at that time. Similarly with vision loss and all. Now similarly in laryngology emergency, loss of voice or change in voice can have low risk of medical legal litigations, but if they are delayed airway and hypoxia induced brain injury, then that will put you high risk. Why it's important that this is low risk, this is high risk? Because the compensation which is granted to the patient party depends on how much damage they have suffered, and this is the way in which judiciary in India or outside India interpret this. So if there is delayed airway and there is more damage to the patient, consequently the compensation granted will be more. And if there is minor injury or minimal loss, either there will be no compensation granted, or minimal compensation will be granted. Now coming to the head and neck surgery, similarly in the case of head and neck oncology, we can understand that in these surgeries, extensive resections, disfigurement and loss of functions happen, and consequently nerve injury, chyle or vascular leaks may happen, and consequently the suboptimal cosmetic and functional outcomes. And if not informed, if not mentioned in consent and counsel to the patient and the relatives, it may land up in medical legal trouble too. We have to understand in these aspects. Similarly, in the allergy practice, over last 5-6 months, I have seen 4 medical legal cases coming to me because anaphylaxis happened and that was not managed as per protocol as patient party or patient relatives claimed, and the patient lost life due to the anaphylaxis. So if you are doing allergy practice, it's important that you take due diligence, due standard care has been taken to avoid anaphylaxis, and even if anaphylaxis happened, whether you are able to give the treatment as per the protocol. This is important. Similarly, if you are offering immunotherapy, whether immunotherapy consent has been taken and or not, whether the allergy test was interpreted currently and consequently was informed, and the proper immunotherapy was instituted or not, or patient was informed about the alternative treatment or not. Now coming to the medical legal issues in vertigo, the one common source of litigation is delayed recognitions of the central causes and all. These all have these disability claims and all. Consequently, the work related compensation and all these are granted, and that can, so we have to maintain documentations properly. Similarly, in the sleep surgeries, improper CPAP guide, CPAP compliance, whether those aspects are consent, even if we are going for, if we are advising patients for sleep surgery, whether the proper consent was taken and these were counseled to the patients or not. So this is what are the legal why there is a legal requirement of consent. We are discussing for last many years that why consent is needed. That patient claims that in the code of law, patient claims that they are not properly informed about the procedures, and they also claim that, and I have seen in my practice that many a times these things happen. So they claim that no one explained the alternatives, and there can be many reasons, whether they were misguided by their counsel, their advocates to make the case strong or not, but patient many times claim that they were not properly informed. So it's important that we document these all things in the consent, as well as after taking the consent, it is also documented that after explaining these all things and the patient agreed to this, the consent has been taken, which is attached in the file. So many a times this become a very good defense also. Legal standard now demand that this is a part of standard of care, whether we are taking the well-informed, voluntary and competent consent. Documentation is also important, as discussed already. So informed consent is essential. This has been procedure, risk, benefit, alternatives and all. Effective communication is maintained. And what is the role of these consent and all, or these documentations. So these documentation in a court of law, it also proves that a standard of care was maintained while providing the services to the patient. Second, this is a documentation is a proof that due communication was made between doctor, patient, patient relatives or parties, along with the doctor and their subordinate. It is also very important, because in a case sheet, many a times the senior consultant put their notes, the junior resident or junior consultant seeing that patient also put their note. It is proof that they had communicated between themselves about the condition of the patients and all. So documentation is a very important legal shield available to us. Now we'll see the medical legal cases in India, and these are the landmark cases I have selected from across the length and breadth of country, and we'll try to understand what we have to learn from these cases. So how we'll deal with these cases. So we'll understand what were the procedural risks, the inherent complications in surgical and diagnostic procedures, what were the communication gaps, so lack of clear, comprehensive patient interaction, documentation errors. So these things we'll understand in each case. Insufficient or inaccurate medical record keeping was there. So this is the first case, septoplastic complications from Mumbai 2022. So in this, the patient developed permanent anosmia. So in this, the patient developed permanent anosmia post-septoplasty. The surgeon failed to inform about anosmia as a known complication. So outcome was 5 lakh compensation awarded to the patient. So it is important to know that there has been very few or almost negligible medical legal cases related to anosmia developing post any nasal surgery. It is quite common in the Western world, but not in our country. But I have selected this case to show the importance of counseling patients, mentioning even remote, because over the time what we have seen, the courts recognizes that if the patient has developed any rare complication, whether she was informed or whether these has been mentioned in the consent or not. So I have seen in few corporate hospital in Maharashtra what they have developed. If the patient is being planned for surgery, they send the consent even with the remote complications in a form of document which they send over the mail, and they request they take the consent of patient like insurance companies send to us with all their terms and conditions. So the patient, so what they are emphasizing, that if code of law expect us as doctors, ENT surgeons, to counsel more and more to our patient, then it's not about the rights of patient also. Patient has certain duties to be well informed, to be aware about the surgery they are undergoing. So this is one, good practice these corporates in Maharashtra has developed. So now the second case is post-tonsillectomy death. This is from Kerala 2018. So in this, excessive bleeding post-tonsillectomy was not promptly managed. So the thing is that excessive bleeding post-tonsillectomy will never land you in medical legal case. But if it is not promptly managed, then that will land up. So failure in post-operative monitoring and immediate interventions, and in this 25 lakh compensation was awarded to child parents. Now coming to this case from Delhi 2020, facial nerve injury after mastectomy. So patient developed a facial palsy post-mastectomy. Inadequate disclosure of facial nerve damage risk in the consent form, and 10 lakh compensations awarded to the patients. So now this is about fourth case, missed foreign body aspiration. This is from Gujarat 2016. So in this, child aspirated a peanut, severe respiratory distress developed, and the negligence was failure to perform immediate bronchoscopy despite clear indications. So 20 lakh compensation awarded by the court. So this is important. So case 5 is tracheostomy dislodgement death. This is from Chennai 2023. So in this, tracheostomy tube dislodged overnight leading to death, absence of trained nursing staff, and equipment devices, rupees 30 lakh compensation awarded to the family. So many times we have to develop protocols. Suppose we are a consultant or we are a doctor, ENT surgeon in any institute in which there are residents throughout the night also, or there are resident who can take care. So we have to devise our protocol like that. Like when I was resident in Safdarjung Hospital, we had some PG first, PG second who can manage tube dislodgement. So there was no protocol like we have to secure the tube and all. But when we entered corporates and all, there was protocol that after tracheostomy we secured the T-tube with suture and all. So we have to develop our own protocol in line with the what is expected from us as a ENT surgeon based on the institutes, whether there is ENT 24/7 in that hospital, or we have ENTs during day only. So to take care of these, because if tube is dislodged, if in the immediate vicinity nobody is able to manage, we can't reach to hospital in such a narrow time, such a less time. So these case 6, 7, 8 is related to anaphylaxis. So in this basically the patient developed severe anaphylaxis, and the court awarded 51 lakh for inadequate allergy screening monitor. This was related to IV fluid, and this is related. This is also related to anaphylaxis. Now, this case 9 is what happened in this case. In this, there was not proper communication from ENT and the anesthesia consultant. So it's important that the surgeons should communicate properly things to the anesthesia consultant, because at the end both will suffer if this court case land up in the court, and this was happened in this case. So it's important that now this is another case. In this critical pre-operative vigilance and critical pre-operative and post-operative vigilance is important. And in these two cases, which were very landmark in themselves, the surgical gauze was left in nasal cavity. The case is from Jaipur 2019, and in this this Ricipsa liquid was applied and awarded 7 lakh compensation. So this means that the fact speaks for him itself. Means the surgical gauze left in the nasal cavity and thereby leading to some complications. So it will itself, there was the standard care was not followed, because leaving a foreign body, leaving a foreign material is itself a negligence. So consequently, no, if these things happen, that Ricipsa liquid is applied, no one can save that person. There will be some good amount of compensation or some things beyond that, but it will not that the case will be the doctor will be acquitted of the case. Similarly, this is a case from Kolkata 2021. A surgeon mistakenly operated on wrong ear, and the gross negligence was found due to failure, and the failure in verifying the correct size, and 15 lakh compensation was awarded. And this is one case. And in this case, the patient was operated for stapes surgery, and patient developed bleeding, and that was not recognized in time, and there was delay in referral to the higher centers. Patient died. So it is very rare in any ear surgery. Basically, the patient died post surgery, and this case went against the doctor even in district forum as well as state forum. So it's important that we are able to recognize the complications well in time, and we are able to, if at our center we are not able to manage that complications, whether we are able to refer to higher center within time as per following the referral policies of our country. So what are the quick defense tips? We'll quickly revise and understand this in proper documentation. So maintaining meticulous record of all the patient interaction, diagnosis, informed consent, ensuring patient fully understand risk, benefit, and alternatives of procedures, using digital or audio visual consent, pre-operative protocols, implementing comprehensive checklists and timeout procedures. These protocols were developed only to protect us medicolegally. So we, as a consultant, we should not understand that this is another documentation burden on us. These burden are so that we can practice throughout our life the ENT. We can practice happily. This mental agony, stress of appearing in the court, replying to the notices doesn't happen. That's why these protocols are developed, and we should follow that. Post-operative vigilance, ensure continuous monitoring and prompt intervention for any complication. Another is professional indemnity insurance. Many a times people ask me in the conference conferences as well as my medical legal client, how much indemnity insurance coverage we should have. So if you are a surgeon, be it of ENT or neuro or any other, you should have a indemnity cover of at least 1 to 2 CR, considering current situation in which there is a high chance of medical litigations. And along with that indemnity, you should have less sublimit, like the ratio should be 1:1, 1:2 instead of 1:4 or 1:5. What we mean by this sublimit, that though you have a coverage of 1 CR or 2 CR, but if there is sublimit, they'll compensate, or they'll give you maximum. For example, if the ratio is 1:4, so they'll give maximum 25 lakh in one case. So that is one thing you should know as while taking any indemnity. Now, so these are the things which can put us in a medical negligence or medical litigations, medical legal litigations. So documentation error, billing issues. Recently, 2 months back, one case came to me related to ophthalmologist, in which due to billing issue, doctor as well as the hospital was sued. So we have to as a doctor, we should also be mindful of these all things before handing over the discharge paper to our patients after the surgery. Consent form deficiencies, authorizations gap, clerical inaccuracy, sometimes with some error in the software. So in good hospital it doesn't happen, but many times in 10, 20, 50 bedded private hospital, these things happen, that date is wrongly mentioned in the discharge summary or during the course of treatment. Many times the insurance claim get rejected due to that only, and many times patient can sue. And I have seen 3-4 cases related to these things in last 1 year. So now this is one important thing, navigating patient aggression. So many times hospital associated violence has become quite common due to one or the other reason. So how to deal with that, and what if some hospital has workplace violence, or hospital at the place in hospital violence happens by patient attendants, what we should do. So early documentation of abusive behavior, record the behavior in a file or electronic medical record, inform police promptly, notify police stations writing, protect property and staff, request patient to leave or involve hospital administrations, ensure staff presence during the sensitive issue and all session. The medical indemnity notification, it's only important that you should involve in case you have medical indemnity insurance for your hospital or yourself, you should involve that. Now with the advent of this telemedicines and all, if we are giving teleconsultations, we have to be mindful of telemedicine guidelines 2020. Though there are some, over the time, after doing lots of telemedicine consultation, I have done more than 1.5 lakh. I have understood that there are many loopholes in the NMC telemedicine guidelines, but as of now, we have to be compliant to that. Consequently, digital consent procedures, proper documentations. So comprehensive checklist use. We can use checklist to make us more compliant to all the obligations or all the things we have to take care of. Audiovisual consent record, detailed follow-up. And it's not that only the consent format or checklist will protect us, because this consent form checklist evolve over the time, changes over the time, and it should be updated. And it's not that if we'll maintain checklist, we'll take consent, will be 100% protected. We have to be aware about the contemporary medical legal issues also, which I'll discuss in the coming sections of the sessions. So we have to maintain a balance into defensive versus ethical practice. Many a times the defensive practice increases the cost of the therapy, cost of the treatment, but somehow over the time that is also needed. Now we are moving towards the era of precision diagnostics. So role of AI and molecular diagnostics is increasing. We'll see how the AI, if we are using AI in our clinical practice, in maybe that can be in trials, appointment scheduling or diagnosis, or while counseling, advising. There can be many. That is a separate topic. I'm not going into detail, but I'll try to. And we all know that I always speak in my AI workshops and all that. This is the way the medicine has evolved over the time. Currently, we are leading the current 2025-26, or the current time is medicine as a biological science, but we are moving towards medicine as a data science. And this is a prediction made by one of the very reputed entrepreneur only, and this is coming true. And consequently, over the time, we'll see medicine as algorithm and mathematics, the era of computational medicines. So, and no regulation, nothing can stop AI to be invading or to be integrating in the healthcare. So we have to adapt to it. We have to understand the good uses of it, and we have to use AI under the compliances and regulations. So that will understand how we can do that. So coming to the what is the regulatory challenge related to when we are using AI in a healthcare? One is fragmented network. There is no fragmented framework. There is no separate AI in Healthcare Act, which is, I feel, the need of the hour. There is critical gap in some validation. But as I always stress upon that, law always stays behind the technology. So AI is a very new technology, and that is rapidly progressing. So law will also evolve over the time to adjust to that. So these are the these are the sections, these are the legislations under which AI in healthcare is being regulated. I'll try to, and these are some guidelines. If we have interest, we can just briefly go through these thoughts. There is not much is being said in these four about the AI in healthcare. So we have, we all know that US FDA categorized AI in healthcare as a high risk AI. So we should, so any use of AI in healthcare should follow these ethical principles. It should be valid, it should be non-discrimination and fairness. I always stress upon in AI conferences, I go as a speaker, I always stress upon that AI has inherent ability to correct some discrimination, some fairness in the terms of algorithm testing, and on that is a part of validation of any AI in healthcare tool. So we have to understand that it should be non-discriminating, and their fairness should be there. There should be optimization and data quality, accessible and equity, risk minimizations and safety, collaboration, autonomy, data privacy. And for data privacy, we all know that that's why DPDP Act has come in India, accountability and liability. So now we'll understand the basics of DPDP, which is important for us as a practicing doctor, as a ENT. So what are the obligations that is expected from fiduciary? So in DPDP, what does fiduciary means? Fiduciary means any doctor or any hospital that has some role to maintain the patient data. And data principle means the patient, basically, who are basically the owner of the data. So what role we have? We have to safeguard data. We have to notify breaches. We have to maintain accuracy, and we have to we have to delete personal data once the specified purpose is full, or when a patient requests it. This is important. So what are the penalties for that? So failure to secure the data up to the 250 CR, and failure to notify of a breach, even if there has data has leaked and you are not able to notify that, then 250 CR plus 200 CR. So we have to understand these things, the huge amount of penalty. So, but over the time, AI is very what I say, very good technology in revolutionizing healthcare, and it's important that DPDP doesn't suffocate the innovation, the research. So this has been taken care in a very good way in DPDP. So this is my AI workshops only, and this is on IMA platform. So we have to understand why using AI in healthcare, we have to be mindful that our use should do no harm. At least should do no harm, And I always stress upon that there should be human in the loop. Means we should not leave everything to AI model or AI tool. We should be monitoring things, especially the moderate to high risk things. Now coming to the basically social media defamation. That is one of the very contemporary medical legal issues we doctors are facing, we ENT surgeons are facing. So the viral video defamation, defaming a particular doctor, a particular hospital, Google reviews, giving fake reviews on the hospital Google profile or clinic. This is one of the common. Similarly, WhatsApp group defamation. These are the cases which has been recently related to the healthcare. So what is defamation under Indian law basically? So section 499 IPC says that making or publishing false imputations intending to harm reputation. Section 500 also mentions that punishment include imprisonment to 2 years. So what I going to civil defamation, which is governed by the tort law, allowing monetary damages for reputational harm. If someone is doing reputational harm to you, or loss of patient, or some loss related to professional practice or something, so there are provisions for monetary damages. And and to prove defamation, what we have to see, the statement was demonstrably false, means the statement which are made against you, made for you, was false, published publicly, either social media, reviews, articles, especially referenced you or your practice, cause measurable reputation harm, made with malicious intent or reckless disregard for truth. So these are the component that is needed while you are proving that defamation was there against you. So now it's important that why it's that there is an increasing incidence of social media defamation against doctors. So one is Consumer Protection Act. So there was amendment in Consumer Protection Act 2019 which has shifted perceptions. Doctors are viewed as service provider, not healers. Patients expect guaranteed outcomes. So nowadays it's important that your patient selection of particular surgery, particularly cosmetic surgeries, is very important. Treating complex ERDs, like they want guarantee, which medicine can't give for sure, for 100% surety. I always say in conference that 100% guarantee is either given by God or fraud. So however good we are in our field, we can't give 100% guarantee for anything. Now there is Dr. Google syndrome. So patients self-diagnose using incomplete online information, developing unreal. Patient read things on ChatGPT, and in ChatGPT there is a chance of hallucination. They may give you some incorrect information with such a confidence that it appears to be true. So these things unnecessarily increases the expectation of patient from some particular surgery, from treatment, and consequently we doctors are expected to fulfill that raised expectations of patients. There is Gen Z culture. So these young generations of Gen Zs, they feel instant gratifications after posting anything online, and somehow online anonymity removes accountability and empathy. And what are the reasons? There is social erosion of trust. We all know that post COVID-19 or during COVID-19, what has happened? Ethical dilemmas. So balancing patient privacy with self-defense against false accusation, political exploitation. We all know that. So what is the way forward? Medical association must establish dedicated reputation protection cells, mandatory digital conduct training in medical curriculum. So somehow our practice or our medical curriculum is not evolving to that extent. How our society or medical practice or the integrations of these all issues, the rising medical legal issues, social media, role of social media and all, is affecting our clinical practice. So it's needed that we should do that. Now, what are the legal remedies available for us related to social media defamation? So I'd like you to, this is one very good slide, you can take a screenshot of it. So criminal complaint we can find in file in magistrate case, and the relief is imprisonment or fine. Similarly, cyber defamations under IT Act, medical, we can complain to medical council, and even that is related to some press, some electronic, some print media and all, we can file a complaint as per the Press Council Act also. So how we have to deal with this social media? So we have to document everything immediately. We have to issue legal notice, document everything immediately. What I mean by that, for example, someone has put wrong information or has tried to defame you on social media, take a screenshot of that with date and time stamp. That is very important. Why? Because once the person who has posted, if they understood that now it is becoming a big issue, they'll delete that, and you will have no evidence. So first do thing, take a screenshot with date and time stamp, issue legal notice within 48 hours, file cyber complaint, engage professional body. So I am in the IMLIA, that is one of the largest medical legal associations. So we have separate policies to deal with these all things, and we all in our national annual conference we deal these all things. So we have to engage professional body, issue professional statement. So protecting your practice, so enhanced communication, comprehensive documentation, digital patient education, and staff training. Many Instagram influencers who are not doctors, who doesn't have any degree in healthcare, are misguiding patients. Just they are googling, they are reading the things on AI and misguiding the public. So we as a doctor have responsibility in our hospital, clinics, as well as through our social media profile, be it YouTube, be it Instagram, to create awareness about those prevalent misconceptions, and we'll gain a lot after by doing this. If we are doing, our whole fraternity will benefit a lot. So at the end, I'll always like to say that first communicate, then operate. First document, then defend. If there is a consent, there will be confidence. So operative excellence must be matched with documentation, discipline, and aggression management in this contemporary time of rising medical negligence. And we all acknowledge that skill is essential for saving lives in critical situations, and notes is important for career advancement and documentation. If you want that we practice with a peace throughout our life, then it's important that we should do this. And calm is important to deal with if somehow hospital associated violence happens. And in ENT, it's important that it's not just the scalpel in the OT that protects the patient, it's your pen that protects you and your calm that protects your center. So that's all. I'll be happy to take any questions, and this is about my medical legal form. So I take cases of doctors and all. These are few books published by me.
Yeah. Thank you, Krishan Rajbar. That's a wonderful presentation. A complicated topic in almost like a 45-minute nutshell is a wonderful presentation. Yeah, being in service, we are being, I don't say attacked, but there is a change in perception from the public. The doctors have to be careful right from the minute the patient walks into your chamber. There are video recordings. There are, they instigate you to talk, more. So you got to be matured. And then, as I said, that as you also have mentioned, that the communication and documentation are the armamentarium in this battlefield. I would say, if something goes wrong, as long as everything is fine, you are a god. If something goes wrong, you are a devil. So you have to be adjusted to both ends of your personality when projected that way by the public. So wonderful thing. I have a question like, how long do we have to keep the medical records of any patient?
Okay, yes. So, sir, there are there are many guidelines. There are NMC rules for that. In the Clinic Establishment Act, there are rules which is differing slightly in different districts. But if we'll simplify it, and there are separate guidelines for electronic health record, means digital record of the patient. So overall, if it is related to your OPD, it's 3 years. And it's IPD, it's 5 years. If it is pediatric patient, we have to maintain record till child become 18 means we have to, if we have seen a pediatric patient at the age of 6 months, we have to maintain for 18 year plus 2, because law assumes that at the age of 18 year he will have the right to what to do with that record or something like that. So 18 plus 2, 20 years for any pediatric. But for normal OPD 3 years, IPD 5 years. For medical legal case, we have to preserve till the case is being disposed of. And related to digital EHR and digital health record, it is as per the DPDP Act. And in DPDP, government has just notified DPDP on 13th November 2025, and DPDP implementation is in the phase manner, means over the next 1.5 year. So what they have mentioned regarding the healthcare and all that, the patient will be the owner of that. So if the patient says that delete my data, then we have to delete it. The patient has only say in that. And if they are saying, and we are a custodian of data, and we have to keep that. And if patient says that delete that, we have to delete. But they have said about e-commerce data that we have to, if the patient hasn't taken your service for last 3 years, you have to delete it. But they have till now they have nowhere mentioned this, that what to do of healthcare data, whether if the patient hasn't taken a service for last 3 years, then we have to delete it or not. But having said that, it's if even for deletions we have to till now, as there is no mention of that whether we have to delete it if there has been no service taken to the patient in last 3 years. But it's important that for digital data, for the deletion we have to take the consent of the patient.
Thank you. We'll go to the next question, which is
Sai?
Sai?
I just want to ask a question here that, see, there have been a lot of guidelines and consent for each procedure that they have come up with now. See, for a stapes surgery, there is separate consent. If you are doing mastoid surgery, separate consent. So do we need to see that when you take a consent from the patient for any surgery, will it holds good for all the surgeries, or in specific in ENT for each procedure there is a separate guidelines are there for the taking consent?
Well, regarding this, there are guidelines by the professional association like AYA, or even for different specialties, they have different guidelines. But code of law, what code of law stress upon that, that if the consent has been handwritten, or code of law doesn't want that we should have a template consent, like what we have seen in many corporates. What they do, they have a template consent form, and they fill it for all the surgeries of ENT, or for all the surgeries of not only ENT, any surgical specialty. So code of law doesn't like that, because technically speaking, that is not customized as per that. So what code of law expects, that we should ideally take the consent in the handwritten format, because we all know that even the risks, benefits, things vary from patient to patient, from surgeries to surgeries. It's like that. And the professional associations are coming with template consent and form that can help us to some extent, but we should not make it as a final truth.
Can I interrupt you here a second?
Yeah,
when
please.
you say handwritten consent, if you think that the patient has to undergo tracheostomy, I don't think he'll be in a position to give it in handwriting. So how would we deal with that situations?
So what I mean by that, we can, for emergency, even code of law understand these all things, that tracheostomy is an emergency procedure, especially if you are doing emergency tracheostomy in that case. So we can justify those things. Even it's not like that I'm saying that,
or even an illiterate.
Court prefers that the consent should be handwritten, and what is their logic is that we can customize this as per the. But even if it is digital and we have all facilities at our centers, we can, and for emergency procedures, especially those procedures that are life-saving, we can customize, we can use our judgment in those things.
Can we have a template for all mastectomies? Can we have this thing for all different procedures? Can we have a templates?
we can have templates, but that template should be updated over the time. It's not like that one template is there which was developed 5 years back and we haven't brought change, because things evolve. Like the first case which I have discussed, even though they have taken.
Yes, sir. Sorry.
See, sir, one example I will tell you. Suppose if a patient comes for a stapes surgery, if you explain the patient about all the complications like perilimb pressure, there is a chance of facial nerve paralysis, there is 1% chance of sensory hearing loss, there is 1% chance in. So no patient will undergo surgery. It is like,
Yes, sir, yes.
frightening the patient by telling the textbook complications. So now you need to balance actually between the consent and your experience. Whatever you tell, you have to tell in your experience. See, I'll tell you one incident. One patient, about 10 years boy, about 2 years back, when I was operating him for an adenoids, he asked me, the 10 years boy, before intubating, sir, how many surgeries you have done so far? This one. So will it be safe in your hands? So even a kid can understand and he wants to ask the experience of a surgeon. So there is nothing wrong in patient knowing. So whatever I think we tell them that we need to tell about not the textbook experience or somebody who has done thousands of cases. So we need to tell our experience and our setup what best can be done in our hands. I think that should be realistic to the patient than explaining about everything and frightening them. What do you say, Sai?
What I've seen, when I've been in UK, how they counsel, it's a long process, like they take a lot of time counseling the patient, and they want the patient to give the response till such time they don't put the knife on the patient. So if I seen a consent taking for a transperinodal pituitary, the surgeon asked the patient that I'm going to do this way, the procedure he explained, and then he said that there is a chance of your blood vessel getting injured, internal carotid artery, what he means, and then you may die. This is what exactly the question he has put to the patient, and
My
the
God.
patient
Huh.
thought a second, and do you give the consent? That's what the surgeon asked. Then he said that he thought a bit, and then he gave a consent saying that yes, I'll undergo. So looking at that, even I started telling every damn thing what could be a possibility. But again, like a video counseling, how much it helps. Even if you are so frank with the patient, even if he says that the doctor has not told me anything, what is the difference? The documentation or a video counseling?
Sir, both have their own role, but it's important that even consent will be anyways be a written documentation proof for that. So video consent has also their own place, but we have to keep our judgment in that. But I think written consent will hold as good as video consent. But if you feel that in this case there are some different kind of complications or something like that, and my judgment says for that I should take a video consent, you can take video consent, will hold truth. But what I was discussing in the sessions about that Jahangir Hospital in Pune, what they have started particularly, they have before, while the patient is being planned for surgery, they send a mail to the patient with all the remote consultation, remote risks also in their disclaimer or a kind of consent only, and the patient read it and digitally sign it. So somehow we all know that how rare those complications are, but it's important that whether patient was informed. Many times what happens that patient doesn't read it, just as we do for any while buying for any insurance or any things, we sign it without reading it. Patient also does that, but in a court of law, what happens if that patient has some rare complication, court, hospital or doctor can defend themselves that we have sent a document to the patient and patient has digitally signed it, and that was expected after reading that document. So patient were well aware that these surgeries can undergo, and we always can defend that it is routinely impractical. It is not practical to include all the remote rare complications in the consent routine for the routine surgeries.
Thank you, Krishan. There is one interesting question from one of the viewers. Kavita. She's asking like, how does consumer court address government doctors and or Ayushman beneficiary also liable to go to consumer court? What is the legal standpoint in wound infection delay healing? So let's put it like as a two questions. One is that if you are operating a surgery for free of cost or in a trust hospital, are you still can be implicated if there is a complication? You have not taken any money.
Yeah, this is good question, sir. So suppose in particular trust hospital, I am giving my service or the hospital is giving service free of charge, completely free of charge. Then you have some legal immunity. But if I am giving free service to some category of patient, I am charging others, then I'll be liable as in the same way as any private practitioner or a surgeon in corporate will be liable.
So what is the legal standpoint of view in case of a delayed wound healing?
So, sir, as I have touched upon this thing also in the session, that complications may happen, but it is important that whether we are able to recognize the complications and do as per what is expected from us as a ENT surgeons within time, means just when we recognize, whether we have recognized in time and whether we have taken due precautions or due things to manage that.
Dr. Nageshwara is asking, can you ask about professional indemnity? I think you have covered in your topic about professional indemnity. Yeah, there it goes. So any more questions? I did not get. Somebody wants to know, how can we make a handicapped certificate? I think there are standard procedures for that one has to go through.
Actually, Sai, this handicap certificates actually, they are issued by the government certified doctors, because the handicap certificates, they get beneficiaries from the this railway concession and then some type of pension, something
Even
like
if
that.
the private
doctors
gives,
can't do that.
yeah, it is not valid, I believe.
Yeah, it's not valid.
Government has recognized, for example, in Delhi, government has recognized certain hospitals to issue that. So ENTs, ENTs in that only can be.
I have an interesting question to you, Christian. So many obligations for the doctors. Are there any obligations for the patients too?
So, sir, what happens that suppose I have advised certain precautions in any particular surgery to the patient, and it has proven in a code of law that patient hasn't followed those precautions, and the patient has some.
Yeah. No. My question is that now in a given situation of advanced information that is available, isn't it the patient also is supposed to ask certain questions like, do I get, let it be a Google syndrome, whatever it is. See, if they haven't asked, are they not also not responsible?
So, see, in this provider, we are service provider and they are recipient end. So, law always means law is always on their side generally. How society and
the
how
sufferer side, yeah.
But anyways, having said that, justice will be done for both parties. It's not like that doctor.
Yeah, but it is our duty to tell whatever we know. We have to update ourselves of knowledge. So it's a beautiful topic to select, JP. I must congratulate you. Thank you very much, everyone, for participating and the questions you have given. Thank you. Anything else, JP? Please.
Yeah, from APAOI State Branch, we thank immensely Dr. Krishan for taking up this, and he has vast knowledge also. I just came to know that he has written so many books. From one of our AOI delegate has telephoned me about some PG, this one also. So I congratulate him for doing such a good work in this young age, and where I think this litigation is there everywhere and anywhere and anytime, but it is on increase. So because of that, we need to document, communicate with the patient effectively, and be compassionate and be empathy. So we need to be little empathetic to the patient, not like harsh way to deal with. I think that most of the things he has covered is a vast topic, and I congratulate Dr. Kishan and thank you very much for. I thank both Dr. Sai Balram and as well as Kishan for his moderation as well as speaker. Sahu,
Sir.
Apparao sir is online. I think is there. Apparao, sir. Dr. Apparao
Yes, sir.
sir.
Sir is there.
Just ask him to unmute.
He is on mute. Yeah, he's on.
Okay, no problem. Sahu, you want to say something?
Yes, sir. Yes, sir.
Vote of thanks and then.
Yes,
Yeah, Apparao
Hello.
sir,
I'll close
Yeah.
this, sir.
Nice
sir.
topic, Reddy.
Sir, your comments finally are welcome.
Good evening, sir.
Very useful, and it's a different aspect of the profession, which is very much needed nowadays. As you mentioned, it needs some empathy and sympathy towards the patient, and that saves a lot of issues.
Yes.
Issues. That's very important. Try to spare some. Suppose we put the time when surgery needs more time, we don't mind doing for 3 to 4 hours in the cholecystomy surgery. Why don't you spend some 3 to 5 minutes to explain the disease also? That's very important part. So it takes some time for counseling the patient, explain the disease, and give some time for them also to come to the final conclusion whether to go for surgery or not. Don't make them hurry unless
Yes.
emergency. Emergency is different, but ENT emergencies are very rare. So give some time and let them breathe and let them go to another doctor. Let them go and let it be clear. And if you just tell them that you can go to your family doctor and tell this is the issue and this is what I advised by the ENT surgeon, then they'll be very happy. So we should not be hurry in posting cases. I think this is a important point to be taken by especially junior colleagues and all. Don't be hurry. Take some time and be confident about your procedures and all. Okay.
Yes.
All the best. All the best. The speaker.
Thank you very much, sir. Thank you.
We should congratulate and we have to thank him for the nice topic he has presented. I think we need more sessions like this.
Yes.
Thank you.
We can have one full session actually on consent, one full session on video consultation. We can have one more like this. A lot of things to be discussed, and not only discuss, we need to understand and implement in our day-to-day practice. Actually,
even
thank very much.
State conference also we can have this talk.
Yeah, we'll plan, sir.
Okay, bye. Thank you. Good night.
Thank you, sir.
Good night.
Okay. Thank you, everyone. Good night.
So, sir, once again,
vote of thanks and then close. Yeah.
Yes, sir. So once again, Amar, this side from Pharma Division of Sun Pharma. So today's session was really very wonderful. I give thanks to today's speaker, Dr. Krishnan Rajvar sir, for a very impressive, very informative discussion, guidance for making this evening very enriching in the term of knowledge. I also thanks today's moderator, Dr. Sai Balram Krishna sir, for navigating the entire session wonderfully. My heartfelt thanks to all delegates for attending today's webinar. On behalf of Sun Pharma, makers of Nizact, Cepodem and Montec FX, I am sure today's discussion will ultimately benefit to medical fraternity. Thank you for giving us an opportunity, doctor. As mentioned in the beginning, we have planned a series of webinars. Today, we have completed 40th series of webinars. Such a big series of webinars still yet continuing for years with help of AY Epistate. Before closing the session, we seek your valuable prescription support for our new brand, that is Nizact FT, AZ and OX, which is technically advantage of 360-degree pump and repriming free device with zero drug wastage. We'll soon come back with your next schedule of webinar of the series. Thank you, sir. Thank you all delegates. Good night, sir.
Good night, everybody.